Very nice solid average on that one. Only the one high miss, and it was interesting, like the pretty dead even split between the one high miss question. You guys remember what it was? Yeah, what could slow down the progression of Parkinson's disease? And so you kind of get the concept behind that. Really, when you're using Cinemat or levodopa, like it's really only treating the symptoms of the disease. And in fact, if anything, some people postulate it could actually hasten the disease process. Because remember, when you metabolize dopamine via monoamine oxidase, that's when they think that's when you're getting those free radicals. So if anything, that could actually cause more oxidative damage. So really, if you want to slow down disease progress, they think that monoamine oxidase B inhibitors would be one good option, or using like a dopamine agonist. That way, kind of relieve your neurons a little bit and allow the dopamine acting drugs to kind of hopefully reduce the utilization of the brain's own dopamine, essentially. Kind of make sense? Okay. So anywho, any other questions on that first? I'm gonna start going through the prescriptions. Hopefully, have those graded within about a week or so. Give me some grace here. There's a lot of you guys, and so a lot of those to go through. But and the second one should be up and posted. Have you guys seen that? All right, so good. So you can start working on that, and we're off and starting section 2. So awesome. 25% done. Yay. Okay. So we're talking about rheumatology in general. I'm kind of going to focus mainly just on rheumatoid arthritis, and then we'll talk a lot about osteoarthritis as well, kind of in the same section, because I couldn't find a really good other section to put it in. Keep in mind, I'm not going to cover all of rheumatology, because it's kind of be a pretty daunting task, at least for the time that we have here. I'm not going to cover every single drug that's out there, because I'm sure you've learned in CMS already on rheumatology, like what are some of the main drugs that or some of the like kind of the big blockbuster drugs we're using for some of these diseases. The MABs, yeah, the monoclonal antibodies. So there's a ton of them that are coming out. They all have different targets, and I'm not gonna, have you try to memorize every single one of those, because that's really not our purpose here. I'll cover some of the big ones, talk about our experiences with those. But you guys already know a lot about them, know things to watch out for, things like that. So we'll cover that. But if you have any questions that are kind of tangential to what we're talking about directly, that's fine. We can cover that as needed. And we'll go over Crohn's and ulcerative colitis when we get to GI. So we'll cover that in a little bit later section. So don't think I'll let those diseases out. Anywho, so when you're dealing with rheumatoid arthritis in general, like what's the kind of like the treatment modality? What are we trying to do for the patient? Yeah, prevent flare-ups, certainly. And what is flaring up for these patients? Their immune system, right? Their immune system is overactive. It's not able to distinguish, foreign antigen from self, and that's kind of the big problem we're having here. So we're going to see this is certainly a chronic process, and having this kind of chronically upregulated inflammation is going to cause damage over time. So specifically with RA, we're going to see a lot of joint damage that occurs. Do kids get RA? Yeah, I actually have juvenile rheumatoid arthritis. We have several kids over at Nemours that will treat for that. So there's a little bit of bleed over between the adult, and generally the treatment is going to be pretty similar for the most part. But anyway, right. So we're going to have a lot of attracting all these different chemokines, and all these different immune mediators are going to be getting released here. So mainly thing we're going to focus is to try to tamp that down as best we can. So we mentioned the monoclonal antibodies, which are very kind of laser focused, sort of targeted antibodies against a specific antigen to deal with that immune response. What are some other kind of more broadly acting drugs we could use to treat this inflammatory response? Steroids are going to be a big one, right? Corticosteroids are going to be huge for that. Anything else? Yeah, methotrexate is going to be. How would methotrexate work, do you think? We already talked about that drug before. The folic acid antagonist, which means what? Of what? Yeah, so it helps to prevent, things like thymidine production and things like that, so you can't produce new DNA. But again, we said when you're, giving drugs that affect DNA, affecting mitosis and things like that, like what type of cells get affected most readily? Faster dividing cells, right? Like our hair, the GI tract, but namely in this case, the white cells, right? So again, if we can try to prevent reproduction of these white cells, you can hopefully decrease some of that inflammation that's happening there, right? So if you have less of them available to be attracted to these sites of inflammation, less of them can respond, hopefully you decrease inflammation. So we're going to see, you guys already have, basically, you guys know the main treatment modalities for this. We'll go into more detail on these, kind of where they're suited best in therapy. But yeah, so the same kind of basic process here is going to go for RA, for vasculitis, lupus, gout, all these things. And so we'll look at mainly RA here, but just know that a lot of these same principles will apply to different disease states within kind of the rheuma umbrella. Okay, other important pathways here. So we remember the arachidonic acid pathway. What are some things that get produced to that pathway? We got a lot of prostaglandins, we get leukotrienes. Remember that kind of that pathway that arachidonic acid was affected by both lipoxygenase, but then there's also what was the other enzyme that's important for that to produce the prostaglandins? No, aromatase is for estrogen. That's okay. So cyclooxygenase. Remember cyclooxygenase or COX enzyme? That'll be important as well. So we'll go through these details again just to kind of get you back up on that. But what type of drugs were inhibiting cyclooxygenase? NSAIDs, right? So what's another big drug we use for RA? NSAIDs, absolutely. So again, you're starting to see some bleed over here of the different drugs and the different categories. And yeah, so NSAIDs are a big part of treatment for these patients. And again, we're going to look at some of the kind of the negative consequences of that as well. But anywho, so anyway, so you're seeing a lot of perpetuation of this inflammatory cycle. And again, if we can interrupt that in any way, that's going to be great. So we can either interrupt the activation of the cells with things like monoclonal antibodies, if we can inhibit reproduction of some of these cells with things like methotrexate, or if we can inhibit actual icosanoid production, like the prostaglandins, by using like a COX inhibitor, you start to see different pathways, different ways we can target this. And it kind of makes sense when you see someone who has RA, kind of what the different drug cocktail they happen to be on based on these different target sites. So again, looking through this pathway, remember we have phospholipase, which is where you're going to see a lot of where your steroids are going to be inhibiting. Remember, steroids are kind of working at the top of the pyramid, working down in regards to inhibiting inflammation. That's why they are so potent and so powerful. Also have a lot of side effects, as we know. But the big thing here we're going to be focusing on for specifically an RA standpoint is going to be cyclooxygenase. So we'll look at COX-1 and COX-2 again. Remember, most of our NSAIDs, are they selective for one enzyme or are they non-selective? Typically non-selective, right? So again, that's going to be important for some of the side effects we're going to see, and we'll cover those again. Right, so the main thing we're going to be focusing on is trying to decrease production of these inflammatory cytokines. We're going to try to inhibit cyclooxygenase, use the steroids for things like flare-ups, and more specifically, when you get the monoclonal antibodies, have certain target sites we're going to be focusing on, like certain CD receptors, things like that. So I did that nice wipe there, but whatever. Sometimes I get bored and I'll like put in random wipes. If you see like a star wipe or something, that's probably what's going on there. Anywho, again, talking about rheumatoid arthritis, and again, how does like rheumatoid differ from osteoarthritis? Okay, yeah. So kind of getting more to the pathophysiology of it rather than the presentation necessarily. But yeah, so it's, again, with RA, it's more of an autoimmune sort of inflammatory process. What's going on with OA? Just degenerative, right? So you're going to see that it's more of like you're losing a lot of that synovial fluid. Sometimes like you're getting that kind of bone-on-bone kind of grinding that's going on there, and so treatments are going to be very different between these two. So that's important to remember. Because again, you're not going to use a monoclonal antibody for someone who has osteoarthritis. So try to keep those two and we're going to talk about these at about the same time here. So try to keep those distinctions in mind. Go back to the pathophysiology. It makes sense for what drugs we're going to be using for these patients. But anywho, right, and the big thing we're trying to do for these patients is try to slow down the disease progression. Because what happens with RA patients who are, say, untreated for a long period of time? It's very debilitating, right? So you have a lot of joint issues that develop here. The joints get very malformed, they get very swollen, and so we can have a lot of disability associated with this. And so the main thing you're going to be seeing is that, yes, we want to treat the flare-ups, we want to treat the actual acute symptoms these patients are experiencing, but we'd also like to be able to slow down the disease progression as best we can. So we're going to have a lot of disease-modifying therapy. Think back to MS, which again, also another autoimmune condition. We want to be able to slow that down with disease-modifying therapies as best we can, and then treat the flare-ups kind of as they occur and treat kind of other ancillary symptoms. Okay, so this will be important to remember kind of what drugs are slowing down the disease progress versus which ones are just treating, symptomatically. Okay. Right. So anyway, so we're gonna see, this eventual erosion, destruction of the joints, some pictures here. But again, you've covered this already, so I'm not going to go too in depth on this one. But as far as like from the actual pathophys standpoint, from the the immune standpoint here, you see a lot of formation of antibodies here. A lot of these drive from B lymphocytes. So these are going to be a lot of our targets for our monoclonal antibodies, as you'll see. They'll be able to target specific features here. And again, we will see that there's certain rheumatoid factors that will be produced for these patients. You can sometimes use that for diagnostic purposes, but again, you covered that already. Let's see. And try to get to, these are just different sites we're going to be focusing on. So again, when you're thinking about things like cyclooxygenase and those prostaglandins, this is where a lot of things like histamine kinins, so we're going to see a lot of that kind of swelling and the warmth and edema kind of occurring for those patients. Other big things, though, these T cells is some of these cytokines they're going to be producing, so namely things like tumor necrosis factor, interleukins. These are another big site where a lot of our monoclonal antibodies will be targeting. If they can bind up and neutralize things like TNF alpha, then that can help to kind of interrupt that process of activating other immune cells. So we're going to see that come up again as we go forward. Anyway, you can imagine, someone's joint who has rheumatoid arthritis, a lot of different inflammatory processes going on here. But again, you're seeing eventual destruction of the joint occurring. It gets very swollen, very debilitating. It's difficult for a lot, especially like in the hands, whatnot. They can have difficulty performing just normally activities of daily living can be pretty problematic for them in the long run. So again, if we can slow this down and catch it early, this is going to be beneficial for our patients because it can hopefully stave off that joint destruction for as long as you can. Okay. In comparison, osteoarthritis is going to be much more prevalent. You're going to find, this is just part of natural aging that occurs for a lot of patients. Certainly, certain modifiable risk factors are important here. Are there really any modifiable risk factors for RA? Not really. It's kind of, you're going to get it or you're not going to get it, right? So there may be some environmental factors, but it's not as clear as it is for something like osteoarthritis, where it's just wear and tear on the joint. So if you can do things like, manage weight, if you can, do things like, have good exercise regimen, things like that, that can help to hopefully stave it off. But again, it's just going to happen with time for a lot of patients. And again, big business because they're having a lot of hip and knee replacements happening pretty consistently. I'm sure this number is much higher than it was then. Did anyone know any particular tox issues that come about from some of these joint replacements? Heavy metals, yeah. Which ones? Like Iron Maiden or Metallica? There's actually cobalt poisoning. There were some concerns, and they've kind of switched away from using these replacements or these joint replacements, but they had issues where, and again, these joints are still, even if you replace it with metal and metal, as you're grinding, causing that motion to occur, you're actually releasing some of those metal ions into the body, and so people are developing cobalt poisoning. There's a couple other heavy metals in there, but that was one of the one kind of predominant ones. This was a couple years back when that was becoming kind of a big issue. And the question is like, well, how do you manage those patients? There's not really a whole lot you can do. Hopefully you can get out the joint and kind of replace it with something that would not be quite so toxic, but you can look that up. It's kind of interesting stuff there. Anyway, off that. So just to compare kind of a normal joint versus one with osteoarthritis and then one with RA, again, very inflamed, very swollen here versus with osteoarthritis, you're just getting rid of that kind of bone on bone sort of grinding there. Is there any way we can like reverse this? Any way we can like kind of slow down the progression? Yeah, so there's potentially some injections you can do, look at hyaluronidase a little bit later on, but not to the same degree as we'll see with like rheumatoid arthritis. So again, this is just chronic wear and tear. If you can do things like, I mentioned, having a good exercise regimen, get the weight down, things like that, that can help. But again, this is just going to happen to most people as they get older, develop some degree of this. Anywho, so again, if we can help to decrease a lot of these kind of these disease processes, we're going to hopefully, help to deal with the symptomatic management for these patients. Because again, what's the main manifestation of osteoarthritis? Pain, right? So again, it's a chronic. A lot of patients, end up getting hooked on chronic pain medications. We'll talk about this more in the orthopedic section. I think coming up in a lecture or two. But basically, we'll see that a lot of patients have these kind of chronic pain issues due to osteoarthritis. We're going to have a lot of patients who are utilizing opioids for this, and then they get hooked on the stuff, right? So this is kind of a big opioid epidemic going on, as you know. Going to be a big issue we're going to talk about in the next section when we get to ortho. Anyway. You're going to see a lot of activation of these nociceptive nerve endings, and so there's actually some therapies we can use to try to help mitigate some of that. So we'll look at that a little bit later. Anyone know what drug that is? You can kind of apply it locally to a joint to activate those nerve fibers. Anyone ever heard of capsaicin? We'll talk about that a little bit later. So that's going to be very useful for helping out with these kind of these nociceptive nerve endings and them firing. So we'll talk about that a little bit later. Anyway, they can just kind of see the normal side of the joint versus one with osteoarthritis. Again, you see kind of this eventual destruction happening here over time. But anyway, not to talk too much about that. So getting into the drugs themselves is where I want to focus most of my time on, obviously. Goals for both these patients: if we can relieve pain and stiffness, this is going to be great because again, No one likes to live with pain. The stiffness aspect, is going to be important for helping them to stay active and doing what they normally do. We'll find that we can reduce inflammation. You're going to find that steroids are not going to be as important for osteoarthritis as they will be for rheumatoid arthritis. Have you guys talked about osteoarthritis specifically? How can steroids play a role there? Well, specifically using like glucocorticoids. So think back to our actual steroids. In a positive way, you can still use them therapeutically. We're going to look to see, like, when you're treating a patient for like rheumatoid arthritis, again, it's more of a kind of a systemic issue, right? You're going to find that a lot of systemic steroids get used for this patient versus osteoarthritis. You may see like intra-articular steroids being utilized, and that's going to be an important distinction there, because again, if you can limit systemic corticosteroid use, it's going to be better for your patients from a side effect standpoint, and that's where you can see things like localized injection of things like, triamcinolone and other kind of glucocorticoids can be very useful, kind of limiting that inflammation just in one site. And so again, if you have inflammation present in OA, then we can treat that. Otherwise, trying to reduce the inflammation is going to be the big target for RA, because again, we know the more that inflammation is there, the more kind of progressive joint destruction is happening. Again, for RA, we like to have remission of symptoms, kind of deal with those flare-ups, and we'll see that similar to when we talked about MS, that you're going to have treatment for an acute flare-up, but then more kind of long-term maintenance therapy to try to prevent that from happening and then try to slow down the disease process. Okay, so looking at non-pharmacologic therapy, obviously physical occupational therapy is super important. Do a lot of patients like to comply with this? Why not? It's hard work, but joints hurt. They don't want to do that, so it can be difficult, but it's probably one of the best things they can do for themselves. But yeah, they're not going to want to. So a lot of cajoling and whatever you have to do, maybe bribery, something like that, to try to get them to do this stuff is very important. Weight loss can be super helpful here as well. And then using things like assistive devices, use moist heat, ice, can be useful for kind of for some limited cases here. And then some rest, and then obviously surgery. So for instance, like my mom was having like really bad bilateral knee pain, really bad osteoarthritis for her, and so she eventually had one knee replaced already. She's got a whole host of medical issues, which I'm sure I've alluded to previously, but had one knee replaced, and it's amazing. Like, she can actually get around like 10 times better than she could before. She can actually start to participate in some more of these kind of physical therapy sort of exercises to try to strengthen herself back up, because again, she was not really moving around like she should have been. So yeah, so it's a big deal. So surgery is huge for that, and we'll talk more about that when we get to the orthopedic section next. I believe that's next. Might be GI next. Whenever we get to it, we'll talk about that later. Anywho, so looking at an overview of the therapies we're going to use for these patients. So for RA, you're going to see for chronic treatment, things like NSAIDs are going to be really important, because these are going to help to block cyclooxygenase and deal with a lot of those inflammatory mediators from being produced. And you're also going to see that in a lot of cases, we like to hold off on using chronic corticosteroids, but for a lot of RA patients, they're going to require things like daily low-dose prednisone or dexamethasone or other sort of steroids that we might have to take on a daily basis. Obviously, we know a lot of the side effects associated with that, so there's going to be some issues. Because again, if you think about, from the bone standpoint, what do corticosteroids do in the long term? Break it down, right? You see more osteoclast activity. You worry about things like osteoporosis, and who might have RA? Older females, right? And so those are already at risk, especially once they hit menopause and not producing estrogen. So you can see how things can kind of snowball in a lot of cases for some of these patients that have a lot of these comorbid conditions. But things to keep in mind. Now, for acute exacerbations, this is where things like pulse dose steroids. Have you talked about the term pulse dose steroids ever? What does that mean? Kind of giving like a big pulse of drug all at one time to try to deal with an acute sort of inflammatory state. So you can give, say, like 5 to 10 days or something like that of a higher dose of steroid to try to get the inflammation under control, and then you drop it back down or titrate back down to what their kind of baseline is prior to whatever the acute event happened to be. So these will be used for acute exacerbation. These are going to be one of the most effective things, because again, we're working from the very top of the pyramid to decrease inflammation. So that'll be very useful. And then we'll talk about, for more chronic management, we'll talk about DMARDs. Anyone know what that means? Disease-modifying ARDs. Yeah, anti-rheumatic drugs. Yeah, so we'll talk about DMARDs a little bit later. These are like our disease-modifying therapy when we talked about MS. So you're going to see a couple of similar drugs will show up there, but then we're going to have some more specific ones dealing with this this type of inflammation. And then for the actual knee fusions themselves, you can aspirate. I remember I saw this one kid in the ER who had JRA, and he had to have, I think, I must have had like 180 mLs of fluid just pulled out of this knee. I mean, the rheumatologist was just sucking the stuff out like at a crazy clip. The kid was like pretty small too, and the joint was just massive. But aspiration can be very good because it can help to relieve a lot of that pressure that's there. And then we'll talk about corticosteroid injections. Again, the benefit here of local injections, you kind of mitigate a lot of systemic side effects. You can inject it right to the joint. You try to get most of that effect right there. It can be very potent. It doesn't really cause a lot of systemic effects, which is beneficial. So we'll cover that. And then on the flip side of that, for OA, you're going to find that for chronic treatment, NSAIDs can be somewhat useful. You're going to find some drawbacks to that, but this is where a lot of acetaminophen is going to be utilized. Again, who might acetaminophen not be good in? Pregnant patients, that could be okay. Liver disease, right? So again, think about things like comorbid conditions like liver disease. We'll look at some topical analgesics that are good for local pain. So you're going to find that, depending on how diffuse the disease is for those patients, if it's only like one joint that's really affecting them, you're going to find that some local therapies can be very useful. So we'll talk about some examples of that. For acute exacerbations, opioid analgesics, which we'll cover much more in depth in the ortho section, can be utilized. Obviously, we like to use these as little as possible, short a course as possible, because again, we do worry about things like dependence and addiction for those opioids. And then similar to RA, you can see that aspiration can sometimes be useful here, and then corticosteroid injection will be used on occasion as well. So as I mentioned, the DMARDs are those disease-modifying anti-rheumatic drugs. You're going to find there's a couple of different varieties, the main ones being biologic and non-biologic. When I say biologic, I'm referring to which ones? The MABs, right, the monoclonal antibodies. Non-biologic are going to be things like our methotrexate, teriflunomide, other drugs like that. So we'll cover those. And these are really going to be the cornerstone of therapy. So the earlier that you can initiate these, the better off it's going to be for your patient. Because again, this helps to slow down progression, right? This can hopefully help to prevent, some flare-ups. But in the long term, we want to slow down disease progression. Try to keep that joint as functional as long as we can. You're going to find that NSAIDs and things like corticosteroids are going to be better for more immediate sort of symptomatic relief, right? So this kind of comes back to that question like we had on the neuro test, which one's just treating the symptoms of the disease and which one's actually helping to slow down progression. So this is an important distinction to make here as well. Again, DMARDs, really good for helping to slow down disease progress. Things like corticosteroids, NSAIDs are going to be better for kind of symptomatic relief, for acute relief of issues. So the traditional DMARDs that we have here, the four we're going to talk about are going to include methotrexate, hydroxychloroquine, sulfasalazine. This will actually come back up in GI if you guys talked about Crohn's and UC yet in GI. Yeah, so sulfasalazine you've probably seen already, right? There's a drug called mesalamine that actually gets broken down into sulfasalazine, so we'll see that come up there. And then leflunomide. And these are kind of the more common traditional DMARDs you're going to find. These are the non-biologic DMARDs you'll run into most commonly. Now, if you had to compare dosing between, say, like someone who had leukemia getting methotrexate versus someone with the RA getting methotrexate, how do you think the doses would compare? Who would get the higher dose? Yeah, leukemia patient, right? Because again, you're trying to wipe out basically that whole colony white cells so that you can try to kind of start over and only have the kind of the healthy cells there. Here you're going to find much lower doses that we're going to use, and so the side effect profile will look a little different, but again, it's going to be pretty similar, just in a lesser degree, we should say, because again, the doses are going to be lower. On the biologic DMARD side, we're going to find that we have several that are going to be anti-TNF. So you have things like Infliximab, which I know I've mentioned before, certolizumab, etanercept, adalimumab, and golimumab. This is just a sampling of MABs that are available out there. There are many more that are getting produced all the time. But we'll talk about a few kind of choice ones, some of the more common ones. How would you compare the price of these versus like the traditional DMARDs? Very expensive, right? And then how do these have to be administered? Injectables, yeah. So some of these have to come into the infusion center, have them infused IV. Some of these you can have in a pen sort of formulation, so the patients can inject themselves subcutaneously. That's usually beneficial from a patient satisfaction standpoint. They can just stay home and give it to themselves. That can be nice. However, what's one of the big issues with rheumatoid arthritis? Their hands might not be so great. So from a functional standpoint, so to try to manipulate this pen, have you guys ever seen these pens? It looks kind of like an insulin pen if you've ever seen one. Apologize for not having a picture in here, but basically you'd have to dial in your dose, and it's about the size of a normal pen. Put the needle on the end of it, and then actually inject it subcutaneously. That can be very difficult for older patients with more advanced RA if their hands are really affected to inject those. So again, these are kind of considerations to make when you're deciding what type of therapy is best for your patient. And then look at a co-stimulation modulator, just a different mechanism here. Abatacept is one we'll talk about there. And then we'll look at some that are affecting IL-6. So these would be antibodies targeted against interleukin-6. We have things like tocilizumab and rituximab. Again, most people just call these by their brand names because it's easier to say in a lot of cases, like Actemra and Rituxan. We actually use these quite a bit for a lot of patients with GI autoimmune conditions, so we'll see these again as well. And then this actually is kind of a unique, kind of novel mechanism. This is what we call a JAK inhibitor. We have tofacitinib or Xeljanz, so this is kind of a new one. I haven't seen these too much, but we'll look at that and see how it's kind of a novel mechanism compared to a lot of the other ones we've already looked at, or we'll look in more detail. So we have other agents that we've used, and some of these are agents we've used in the past. Some of these are more for patients who have kind of failed kind of the traditional therapies. So I won't go into too much in depth on these. However, just know that you may see different medications than what we talk about specifically here being used for RA. There's a lot of options that are out there, a lot of immunosuppressants that are out there. And again, a lot of these drugs you're going to see pop up in other disease states where you want to help suppress the immune system. So you think of any examples? So transplant's a big place where you see that. So again, if you have like a lung transplant or any kind of transplant, you want to avoid graft versus host, right? You want to avoid the patient rejecting the tissues that you've transplanted. So you can utilize immunosuppressants to kind of help with that. So you'll see a lot of these being utilized for those patients as well if you ever work at the transplant unit or anything like that. We actually used to use gold for these patients. Have you guys mentioned gold being used for RA? Yeah, it's kind of an old school thing. I've never seen it being used, but we'll find that a lot of heavy metals do typically have some properties that can either be, things like silver has antimicrobial properties to it, gold can have anti-immune properties to it. So different metals have been used in the past, but there's also a lot of toxicity that goes along with them, so we don't use them quite so often. Wasn't necessarily from a cost standpoint, because I can tell these biologics are way more expensive than most of these old school drugs that are listed here. But anyway, cyclophosphamide, where did we talk about that one being used before? And in cancer, I remember it was one of the alkylating agents we use. So sometimes you'll see that even being used to help decrease, similar to how it works for leukemias, you're just using it at a lower dose to help manage that. We also see it a lot for some of these drugs being used for kind of autoimmune sort of kidney issues as well. So you have a lot of kids that are coming in being treated for like glomerular nephritis and things like that, or lupus-related nephritis. So you see these being used from a nephro standpoint occasionally as well. Okay, so some considerations here. So the mechanisms for a lot of the DMARDs are not going to be well known. We don't know a lot of the downstream mechanisms for necessarily how they're working to slow down disease progression. We do know their main mechanisms, and that will inform us in knowing what their side effects are going to be. So that will be an important consideration there. And in general, we're going to find that methotrexate and hydroxychloroquine are going to have typically the best efficacy to toxicity ratios. So in a lot of cases, you're going to find these are going to be some of your more kind of first-line sort of drugs to recommend for patients with RA. Hydroxychloroquine is kind of a new one for us. We'll look at that one in just a little bit. However, you're going to find hydroxychloroquine is a little bit kind of weaker, kind of a wimpier sort of DMARD than you see like a methotrexate. So even though it's less effective, it also has a lot less toxicity. So in some cases, some patients this will be beneficial. One of the big things we're going to see is that combination therapy is going to be important here. So knowing which drugs to mix together is going to be an important consideration here. So for instance, mixing appropriate mechanisms. So not having two TNF blockers, right? Because again, you only need one of those to do that. So again, using complementary mechanisms will be important. I know I'll probably put some test questions on there saying, hey, patients on methotrexate for their RA, what would be a good drug to add on to that? And so we'll look at some examples and we'll kind of walk through that a little bit later here. So anyway, methotrexate and corticosteroids typically are going to be kind of your mainstay of therapy for a lot of patients, and they can be continued by more than half of these RA patients, or at least the first 5 years or so. So again, you're going to start off with the kind of the most well-tolerated drugs, off at first, and then you kind of go through that stepwise approach and add on some of these other ones if they're not really responding that well. And again, you may need multiple DMARDs, as I've already alluded to, but methotrexate generally should be started first line on most patients with RA. Okay, so and again, what's the problem with some of that methotrexate from, like, say you had like a juvenile patient with RA, say a young female, what would be one of the things you have to consider? If they're going to get pregnant or not, right? Because again, a lot of these drugs you're going to see, like methotrexate, is very teratogenic. So again, other considerations to think about. If it's an older female who is already started menopause, less of a concern. However, you want to think about these things, because again, RA can affect all sorts of patients, both young and old. Anywho, but methotrexate, you're going to find there's a lot of good long-term data to support use for this. It's been around. It's a very old drug, been around for a long time, and it's also a really good component for a multi-drug regimen. So when you had to mix multiple drugs together, this is a good kind of backbone for a lot of these regimens here. So methotrexate is a good way to go. So now the DMARDs do not kick in very quickly. They take a slow, they have, or at least the traditional ones, I should say, have a slow onset of action, around 3 to 6 months before you really start to see kind of full effects. So this is why it's important to have things like their NSAIDs and corticosteroids on board as well to help deal with those symptoms, because these DMARDs are going to take some time to kick in, 3 to 6 months, as I mentioned. Especially methotrexate, as we mentioned, is going to be used for most patients. It does take a long time. However, biologic DMARDs, because they are specifically targeting because again, if you think about it from to try to make an analogy back to other drugs we've talked about before, if you think about things like warfarin versus heparin, what was the difference in onset between those two? How long does warfarin take to kick in? It takes a couple of days, like 3 to 5 days or so, right? Because those are helping to decrease production of clotting factors versus something like heparin. How quick does that work? Immediately, right? Immediately gets into the system and can start to inactivate some of those clotting factors. This is similar to this where the traditional DMARDs take time because they're trying to kind of work slowly to decrease production of some of these new inflammatory cells and these inflammatory mediators. However, the biologic DMARDs are going to be able to directly target things like interleukin-6 or tumor necrosis factor. It can directly target that and inactivate those molecules, and then you'll see effect much more quickly. So important consideration there. So especially if you have a patient comes in with, say it's a new diagnosis and they're having a really bad flare-up, this is where something like a biologic DMARD can be really useful to help kind of get that under control quickly, along with things like corticosteroids, because they're going to work a lot faster. Now, all these therapies are going to result in immunosuppression, so there are some considerations there. One, TB testing is going to be really important, especially before treatment of the biologic DMARD. Why do we do that? Yeah, they have latent TB. What could happen if I started them on a biologic DMARD? Yep, negative activations. That would not be too good for your patient because, again, they're not going to have a really strong immune system to fight off that TB in the first place. So that's an important consideration there. And then their vaccination should be up to date for the most part. So try to get those done before you start therapy, because otherwise you can see some either decreased efficacy of your vaccines, or you may find things like those live attenuated vaccines we mentioned. They may actually get activated for patients who are immunosuppressed. Okay, keep that in mind. Again, we're not trying to make them as immunosuppressed as you would see like a leukemia patient. We're trying to kind of wipe out their whole immune system for a period of time. It's going to be more mild, but again, it's all kind of shades of gray there. So some patients may get more immunosuppressed than others. It just depends on kind of the dosing and the regimen they're going to have to be on. Obviously, the more severe the inflammation from the RA, the more immunosuppressant we have to make them to get that under control. So typically, as far as vaccines go, if you can give them before either a DMARD or biologic, that's going to be best, because you're going to get the best efficacy, best safety profile out of those. If you have like a killed or a recombinant vaccine, they can be given during therapy. That's going to be fine. So things like the intramuscular flu vaccine. Anyone know which version of the flu vaccine is live/attenuated? Yeah, the intranasal one. So this would be a case where if you're giving these patients a flu shot, which they should get every year, you would be like, well, if you're on your, say, Humira for your RA, the intranasal flu is not going to be a good option for you because you're going to be immunosuppressed. I worry about that. So instead I can give an inactivated or a recombinant version, which would be like an intramuscular flu. These are things you'll get a better feel for if you work with these patients frequently, but these are things to consider. Pneumococcal vaccine, fine. Hep B is fine. Live vaccines would not be recommended, as I've kind of mentioned, because you do worry about activation of those. And so they actually recommend is the American College of Rheumatology. For them, especially because they are going to be immunosuppressed anyway, they also want to make sure that you're protecting them against some of these diseases where, again, when you get a vaccine, do you keep that immunity forever? Yeah, the durability, it depends, and the durability can be pretty variable between the different vaccines out there, but they do recommend they get the herpes zoster at age 50 instead of when they would normally recommend it at 60, just because they're a little bit higher risk for developing that early, because again, we're immunosuppressing those patients. So again, you'll look at those guidelines and get kind of those recommendations for things like that. Okay. So getting into specific drugs, so first off, we'll talk about methotrexate, since this is one of the most common ones you're going to run into, good backbone of therapy in a lot of cases. How did this one work? What did it antagonize? Folic acid, absolutely right. So again, we're preventing that dihydrofolate reductase enzyme. So basically inhibiting the enzyme prevents these cells from utilizing folic acid like it would normally. You guys remember the antidote for that? Would you give to replace that folic acid that your cells can't use? You can say it louder. I thought I heard the right answer.
I'm just going to say folic acid.
Well, no, you wouldn't get folic acid. You want to get the activated form, which would be folinic acid. Another name, anyone know from chemo? Leucovorin. Remember, leucovorin is another name for folinic acid. That would be something you can give to basically an activated form your cells can utilize when it's being blocked, that dihydrofolate reductase enzyme being blocked by methotrexate. Right. So think about this in those antidotal therapies. This is important because I actually had one case. I had a lady who, an older lady who was injecting methotrexate. She's actually using sub-Q. I don't know why she couldn't use oral for whatever reason, but also one of the things that goes along with age is your memory, right? So I had a patient who called the poison center and said, hey, I use methotrexate, injected subcutaneously for my RA. I think I might have taken a double dose. And so we're like, oh, well, that's not good, right? Because we worry about some side effects associated with that. We worry about immunosuppression, and what you'll find with some of these medications, especially with the sub-Q form, like you can't really do anything with that. Once it's injected, it's there, and it sticks around for a relatively decent period of time. So we actually end up having to do things like give her like leucovorin to replace that. Folic acid would be good. If you had someone who had just a ton of methotrexate on board, do you remember that enzyme you can give that would actually break it down directly, the drug? Remember glucarpidase, so that Varaxase was the brand name. That's the thing an enzyme will give for if you use more in chemo patients who accidentally have way too much methotrexate on board, they can't clear it. But just trying to call back, see if we can dust off some of the cobwebs from those previous lectures, right? Anywho, right, so it's going to be inhibiting that dihydrofolate reductase, preventing utilization of folic acid. This is going to help stunt production of things like thymidine, cysteine, methionine. So again, some amino acids can't be formed. Production of DNA is going to be inhibited through this process, and so again, you're going to be eventually kind of halt replication of some of these immune cells, namely your white blood cells. And again, just looking at how this works, so looking at tetrahydrofolate, very similar structure to methotrexate. And just by being in this mimic here, it's able to get in there and inhibit that dihydrofolate reductase. And so basically you just kind of stop this whole process here. And unless you provide something like folinic acid that can kind of bypass that, your cells are kind of done at that point, right? And again, these are lower doses we're giving these patients. We're not trying to wipe out the whole immune system, just try to tamp it down a little bit. So looking at the toxicity, we see that, again, those rapidly dividing cells are going to be the biggest thing that take a hit. So bone marrow suppression is going to be an obvious one because that's what we're trying to use it for anyway. The GI and oral epithelial ulceration, so you get that stomatitis that can form from that. Again, lesser degree than someone taking this for cancer, but still a concern. And you will see a lot of GI upset with this one. We'll see some hepatotoxicity. It's a possibility. So again, watch out. They have previous liver disease because they can see some further damage there. And obviously some other things like pulmonary fibrosis. It's pretty low risk. But again, these patients with RA, are they going to be on this for a short period of time? How long are they going to be on for? Probably for life, right? So again, these are things you have to think about, in the decades since they could develop over the long haul there. So again, these are things that may develop several years down the road. Yes, ma'am.
Do you see more of the GI issues when taking it oral versus sub-Q?
I would see more of it from the oral standpoint, and again, a lot of it goes back to kind of what dose they're taking. But certainly, you can still see nausea, vomiting associated with it. Even we see given IV sub-Q, you can still see that. However, it's less on the GI route. And again, the thing is, if you throw it within an hour, so like you might have to retake that dose, which is already nauseous to begin with. You may have to think about giving them something like a Zofran prescription or something. That way they can kind of pre-treat themselves. And that way they can make sure they keep the methotrexate down. Right. So things to think through. Other things, we've got to watch for renal function as well. And again, as patients get older, what does renal function typically do? Decreases, right? So you have to watch out for this because these are other issues you can run into where they can start to accumulate more drug over time. You may not realize it unless you check the renal function, because you can still check methotrexate levels, but you may not do it super routinely. And those levels will build up over time. You get more and more immunosuppressed. You get more and more hepatotoxicity, things like that. So again, watch the renal function. Because remember what we give, because we worry about the drug precipitating out in the urine or in the kidney specifically. Remember what we gave to prevent that? So sodium bicarbonate, we're going to alkalize the urine. It helps to increase elimination there. So again, kind of think about the things we would give. You'll see this if you ever work with like hemonc patients or getting methotrexate. You'll see a lot of bicarb being given with that, and that's to help prevent any precipitation of the methotrexate in the kidneys, and that helps to prevent any kind of acute decreases in function. It can be very useful there. So contraindications, obviously, this is teratogenic, not to be given if the patient's pregnant. Mentioned that renal insufficiency, not a good option for them. Kind of a relative contraindication with chronic liver disease. Again, you just need to make sure these could exacerbate that potentially, so maybe one you want to avoid there. And then obviously the blood dyscrasias, they have an existing leukopenia, thrombocytopenia. This is only going to worsen that potentially. So those are things just to kind of keep in mind as far as like relative contraindications go. Obviously the pregnancy is an absolute one. We would not want to get those two together. Okay, so I mentioned most commonly used DMARD, pretty effective. Again, you may see some start of the onset of effects from around 1 to 2 months, but it may take up to 6 months before you really see kind of full effects there. And it's pretty acceptable levels of adverse effects compared to some of the other ones we'll look at. Again, you can get this PO, sub-Q, intramuscular, just depends on kind of what the patient prefers, what they're able to tolerate. And then as far as monitoring goes, things like their CBC, their LFTs, serum creatinine, certainly a baseline, kind of follow that. And then, they're, potentially of childbearing status and, check their pregnancy status as well. Now, some patients will receive folic acid along with this in order to try to, and again, the efficacy is not necessarily going to be super proven, but basically you give folic acid just kind of as a prophylactic dose to try to help out kind of the normal healthy cells, try to help them kind of stay in business. But again, methotrexate, that's directly interfering with the ability to utilize that, but you may still see this being used occasionally, either 1 milligram given every day, or they may do like 7 milligrams, say like once weekly, something like that. So kind of plus minus, but some patients will still get that. Okay. Next up, we have leflunomide. This is actually related to teriflunomide, which we saw used for multiple sclerosis a couple lectures ago. So this is related to that. Now this one's going to be inhibiting pyrimidine synthesis, so very similar to other sort of anti-metabolites we saw in the cancer section. Is going to help to decrease that lymphocyte proliferation there, right? It's actually a prodrug that gets converted into teriflunomide there. You'll find the efficacy is going to be pretty similar to methotrexate. Again, it's going to take some time to kick in, being a traditional DMARD. Again, this one you may see a little bit faster onset, so maybe effects within a month or so, but again, it may take a few months for you to really see full effects there. As far as adverse effects go, diarrhea is probably going to be the most common one they're going to run into with that, so again, be careful from that standpoint. And then you will see things like hepatotoxicity, immunosuppression, so we're kind of expecting that with these drugs kind of in general. Remember how we mentioned with teriflunomide for MS is that drug stuck around for a really long time due to that enterohepatic recirculation. So if you had a patient that wanted to get pregnant, like the drug can stick around for months. You may need to do that cholestyramine washout where that will, and again, how's cholestyramine work? Yeah, it's a bile acid sequestrant, right? So it can actually bind up the drug as it gets sent out of the biliary tract, bind it up, and then you just eliminate it through the feces. So that can be very useful to help drop those levels a little bit quicker. Okay. And again, monitoring can be very similar to what you would see for methotrexate. You don't have to worry about renal stuff quite as much with this drug. So if they had a history of renal disease, perhaps this might be a better drug than say methotrexate would be, right? So these are things to consider. Next up, we have hydroxychloroquine. So this is going to be probably the least potent DMARD, but it's also going to be have the least side effects associated with it. So if you had someone who's kind of very early in the disease process and you were able to give them something kind of mild like hydroxychloroquine to deal with their mild symptoms, that could work, but you may see it used more often in combination with other traditional DMARDs. So rarely by itself, but sometimes you'll see it in combination. And again, this mechanism mainly going to be inhibiting things like neutrophil locomotion, so they're not going to be able to be attracted to the site of inflammation quite as well. Sort of decreasing this chemotaxis with the eosinophils, and also kind of helps with these kind of complement-dependent antigen antibody reactions. So if it can help to prevent some of the activation of these immune cells, and that will help to decrease the overall inflammation that's happening here. Again, takes a couple months for the response to really kick in, but the nice thing about this one is not really associated with myelosuppression because it's not really doing anything with the production of DNA. It's not really acting as an anti-metabolite. So that's one really good thing. No real evidence of hepatotoxicity associated with it or issues of renal insufficiency. So, very mild drug from that standpoint. Very few contraindications. However, it may not be good for patients with more kind of moderate to severe disease. So it's one thing to think about. Okay. You'll see a lot of GI side effects associated with it, so they recommend taking it with food to help mitigate some of that nausea, vomiting, diarrhea associated with that. And then other kind of unique things you can see with it includes this retinopathy. So you do want to watch out for things, check their visual acuity at baseline and follow up. Look for things like blurred vision, impaired accommodation, things like that. And then you will see some dermatologic conditions or issues pop up, things like increased skin pigmentation. Again, this is more of a chronic effect. You'll see that you have this kind of grayish discoloration of the skin that occurs there over time. So watch out for that. Next we have sulfasalazine, and so this is actually another prodrug. And again, do you guys talk about using this for Crohn's disease or ulcerative colitis? Right, so you're kind of somewhat familiar with it. We'll talk about that there as well. But this actually gets cleaved by colonic bacteria into sulfapyridine and 5-aminosalicylic acid. So what does that look like? Yeah, it looks like aspirin, right? So salicylic acid, acetylsalicylic acid is aspirin. That's why I get ASA as the abbreviation for that. But anyway, so you can see how it has some anti-inflammatory properties, inhibit some COX enzyme activity, things like that. But again, do you think you can give this drug IV? Why not? It's a prodrug, has to be activated by those gut bacteria. So again, those are little considerations to think, like why doesn't this drug come IV? Well, this one actually has to be activated by those gut bacteria before it can be given, so before it can have its effect. Now, the mechanism here, we're not really sure the full process. Some of it is probably related back to COX inhibition to the salicylic acid component of that, but there's also probably some modulation here of different inflammatory mediators. One of my mentors when I was in fellowship always said, if you don't know what you're talking about, you can always say modulate, and no one's ever going to question you on it. And so when we don't know why something works, we just say, well, it modulates inflammatory mediators. And so that's usually a good enough answer for most people. See, you guys didn't even know that. I didn't know what I was talking about until just now. So you can use it on rotations. It'll work like a charm. I'm going to modulate this patient's shoulder here and then show them. Anyway. But some other things it can do things like inhibit TNF alpha, which again we'll see is going to be a component of a lot of the biologics we'll look at soon, and also can act as a free radical scavenger. Again, we mentioned that a lot of the damage that occurs over time is due to production of like hydrogen peroxide, those free radical reactive oxygen species. So if we can inhibit that, that'll be beneficial as well. So that can be another component of its efficacy there. Again, response takes a couple months to fully kick in, similar to all the other traditional DMARDs. Some patients are going to experience, about half of them are going to have some pretty significant nausea, vomiting associated with this one, rash, some alopecia. So again, generally try to start with low dose and titrate up slowly, just see kind of what the patient can tolerate. Some people this is not a good drug for them. Also not going to be as immunosuppressive as you're going to see with things like methotrexate or leflunomide, things like that, but you can see some leukopenia occasionally, but it's not as common. And just be aware of some drug interactions. What do you think antibiotics would do to the efficacy of sulfasalazine? Decrease it. Why? Yeah, if you get rid of any of those gut bacteria, that could help to decrease efficacy there. So that's one thing to consider. So you may not want to do that. You have some binding with things like iron supplements, and then with warfarin, actually has some protein binding interactions where you could kick warfarin off the binding site and actually increase its anticoagulant effect. So watch out for that. And then this is another one of those ones that will turn urine, stools kind of yellow, orangish kind of color. The drug itself is kind of red. So again, warn people about that, because again, if you change someone's urine color, they could be very concerning. Because if it comes out kind of orangish or reddish, what are you going to think? Blood, right? And you don't want your patients to think that necessarily. Okay, next we have this tofacitinib or Xeljanz. So this is kind of a unique mechanism here. So this is what we call a JAK inhibitor, and so we're starting to see this one being used more for moderate to severe RA. Have you guys talked about this? Did you mention it? Okay, so again, it's not going to be something that go first line, but say you have someone who has more moderate to severe RA, if they're kind of failing methotrexate, this might be a one they can utilize. And so this actually, JAK stands for Janus kinase, so it's this kind of secondary messenger system we have right here. It's a tyrosine kinase receptor. And we've kind of talked about tyrosine kinase receptors in the past, but basically it's going to help to activate some of these like STAT proteins, and these are going to be affecting inflammatory gene transcription. So if you can inhibit this process, if you can inhibit these enzymes from being activated to increase transcription, then you can decrease the amount of inflammatory mediators being produced there. So again, not as potent as something like a glucocorticoid, which can work directly at the site of the nucleus, but it can help to interrupt this kind of signaling pathway. So it is available orally, which is a benefit there. And so some patients, they can utilize it as a monotherapy. So some patients will do just fine on this one by themselves or in combination with other DMARDs. Again, we'll talk about combination therapy a little bit later on once we get through the biologics. However, this one's not going to be recommended for use with other biologics. That's another important combination thing to look at is you worry about when you have these drugs that are kind of working complementary or in a complementary fashion to decrease the immune system. You worry about kind of having overwhelming immunosuppression. You worry about an infection occurring here. So this is why it's important not to mix, when we talk about the biologics, not to mix two biologics together, right? This is why we don't mix things like tofacitinib with a biologic, because you worry about overwhelming immunosuppression there. So be careful with that. Again, this is another one you want to test for latent TB. That's why they have black box warning for serious infections, things like that. So these are things to watch out for. And then this one is metabolized by CYP3A4, so you want to watch out for inhibitors on board, because that can interfere with it, and you can see levels jump up, and then you can have further immunosuppression occurring there. Okay, any questions so far? All right, let's take a break. We'll come back in 10 minutes and start talking about our biologics. All right, any questions from the first half? All right, so we're moving into the biologics. I know we've alluded to these previously, talked about them to some degree. Again, I like this picture here, just to kind of give you a pictorial example of the different varieties of monoclonal antibody that are out there. So obviously, which ends kind of the business end of the molecule. The claw in there, and they bind them up. Inactivate them, yeah. Anyway, obviously, you can go back to actually look at the name of the drugs, and not that I would ever quiz you on test you on this, but you can tell kind of the protein origin for a lot of these antibodies. So, for instance, if it's chimeric or humanized, you can see here how I have this XIZU sort of nomenclature, so you see that in the name, versus if it's period like a human one, you're going to find that it'll just have a U in the name. So like Immunomab, that would be just a humanized sort of protein there. So again, what clinical relevance does this make? Any at all? What is your body more likely to have an allergic reaction to? Human protein or foreign protein? Typically foreign protein, right? So again, if you have like a purely mouse-based or murine sort of antibody, you can see more risk for having an allergic reaction that can happen there. So that's important. I guess I should use a laser pointer so you guys can see what I'm pointing at. Anywho, more risk for allergic reactions. That's just one thing to consider. However, anytime you're injecting foreign protein to somebody, that is a risk, right? So you do want to watch out for anaphylactic reactions that can happen to those patients there. Anyone know what we used to make old snake antivenom out of? What type of animals? Yeah, I used to use horse. I used to give full horse antibodies or equine antibodies, and they reacted like crazy. Like you're more likely to have to deal with an anaphylactic reaction than you were to deal with actual complications from the snake bite in a lot of cases, because they were just that antigenic. Anyone know what we use nowadays? Sheep use ovine sources there. And then also, what's interesting, what we do nowadays, and you'll see this with the digoxin immune fab. You guys remember when we talked about Digibind, which is an antidote for digoxin poisoning, because it will go and bind it up. What we can actually use, if you use a shorter protein, so if you can use something that will cleave it off here, you'll have it'll have kind of less of a hook for your body to have a reaction to, less antigenic in a lot of cases. And so you'll find that sometimes we use fab fragments and things like that or FAB fragments that will allow us to have less risk for anaphylaxis, but still have a very effective antibody that can bind up whatever our particular target's going to be. So just a little tangent there. All right, so again, biologics, very effective, especially if you have a non-bio or like a traditional DMARD failure. So if someone couldn't tolerate methotrexate and they really just couldn't deal with anything else in the traditional kind of options, you could move on to use something like a biologic. They're very, very effective, work very well for a lot of patients. However, they are very expensive. These can cost thousands upon thousands of dollars. For your patients. In some cases, you're going to find that they will have assistance programs that are actually set up. So for instance, like we do one for Humira or adalimumab, where we will actually get patients started with their first dose for free in the hospital, and then when they come out, they'll have people from the company who are set up just to kind of work with the patients to find ways to pay for the drug, either through assistance programs or coupons, and obviously their insurance plays a big role there. But it's very important they have support systems to kind of help them pay for this stuff, because it can be very expensive, especially if you have patients who have kind of poor to no insurance from that standpoint. Anywho, the other big thing is very little monitoring associated with these. You don't see a ton of hepatotoxicity. You don't have to worry about renal dysfunction. You know, obviously they're not going to directly suppress the actual white cell counts like something like a methotrexate would, so you don't have to monitor CBCs as much. However, you do want to worry about increased risk for infection, so you do want to watch for that. And that's especially important nowadays, especially this time of year, because what is a big risk? The flu, right? Because again, our flu vaccine tend to not perform as well as we would like, and a lot of people are dying from the flu this year, right? And these people would be at bigger risk for it, right? Again, we mentioned TB risk as well, so you do want to screen for that prior to starting therapy to avoid starting in some of the latent TB infection. Also, you probably don't want to start it while a patient has an active infection. Kind of wait for them to get over whatever infection they happen to have, and then you can start therapy up for those patients. And then we mentioned already why we don't give the live vaccines, and that is because we're about disease activation or the vaccine causing disease in those patients. So you do want to watch out for that. So the first target we're going to focus on are going to be these TNF alpha inhibitors, and so we're going to find these tend to have pretty consistent side effects amongst the group. So we'll kind of talk about some more common ones you're going to run into. But again, I'm not going to cover every single monoclonal antibody that's out there because again, that is an exploding market. We're going to find new ones being produced, coming out, almost every day it seems like. So just be aware of that. You're going to run into lots of them. Just look them up, and you'll see they'll have one of these general basic mechanisms here. Where if you know it's a TNF alpha inhibitor, then it basically shares the same side effects as all the other TNF alpha inhibitors. Now, relative contraindication here is kind of unique amongst these is for patients with CHF. They actually have found that when you give drugs like Infliximab or etanercept, they actually have increased risk for cardiovascular death. And again, with some of these patients getting older, with rheumatoid arthritis, CHF is a concern for them. You can have some patients have exacerbations occurring while on etanercept, and so they actually recommend if you have more kind of later stage heart failure, ejection fractions less than 50%, to possibly avoid these agents, right? So that is one consideration if you had someone in CHF. Maybe a TNF alpha inhibitor is not going to be the best drug for them from that standpoint. And then with MS is actually, they recommend avoiding these ones specifically because it can actually exacerbate some of their symptoms. So you may have to be careful for those patients. And obviously if their symptoms start to kind of flare up when they start therapy, then this would be one you want to discontinue. Anyone know kind of generally how long these drugs stick around for? Like how often you have to give them? Because like methotrexate you have to take like every single day, right? It's a daily kind of oral medication, but something like this, yeah, so it's usually on the basis of weeks typically. So typically either every week or every few weeks. Sometimes you'll see they'll kind of get started with a little bit more kind of frequent dosing up front, or they may do it like for every week for 2 or 3 weeks, and then they'll kind of extend it out to say every 2, 3, or 4 weeks. So again, these are drugs that don't clear the body super quickly. So again, if they did have an exacerbation of their MS symptoms, then you would see that would not be an immediate effect. Just because you stop taking the drug doesn't mean that the drug is not still there and can cause issues for a little while. And then there's a black box warning for lymphoproliferative cancer, so do be careful for that. They have especially any history of this in the past. So I'll go over a couple of the specific examples here. These are things that could come up on the test as far as examples and like, answers and things like that. Here we have a etanercept or Enbrel. So again, this will be binding to TNF alpha directly and inactivates it and prevents further activation of that inflammatory cascade. So this will have decreased actual inflammatory symptoms, have decreased joint damage over the long term, and then basically it's kind of interesting. This is the way this one works specifically is actually 2 TNF receptors linked to an FC fragment of an IgG. So by having 2 TNF receptors is able to kind of bind up TNF like it would normally to other receptors, but then once it's bound there, it kind of can't get away from it, and it's further inactivated. So it's kind of a unique kind of mechanism from that standpoint. And then what you're going to see is that a lot of times you can utilize a traditional DMARD plus a biologic DMARD together. That's generally going to be a pretty effective combination. So you see that very commonly, mixing up methotrexate plus Enbrel be a common one you run into. However, typically you don't want to necessarily start with a biologic in all cases. You typically want to start off with like a traditional and then move on to a biologic in a lot of cases. This one tends to have a little bit more frequent dosing, so like sub-Q twice a week. And again, all the monoclonal antibodies, all these protein-based products have to be given parenterally. So just remember that no oral options are available for these for the most part. And with those injections, again, you don't have to know how often to dose them, just kind of know generally that the monoclonal antibodies are going to be given less frequently than like, an everyday sort of oral medication. Certainly you see some injection site reactions. It can happen, kind of a local inflammation that happens right there, and we do worry about that risk for infections. And this one actually is on the cheaper side, about $15,000 per year compared to some of the other ones that are go well and above that for sure. Next we have Infliximab or Remicade. This is one we give pretty frequently. I see this often given for a lot of Crohn's disease and ulcerative colitis patients, all kinds of different autoimmune conditions. We use a lot of Infliximab. Now again, this one is a chimeric antibody. You can tell the X that's in there. But again, very similar. Is going to work to bind TNF alpha, decrease activation of further the later inflammatory cascade, and decrease inflammation overall. And so again, this is another one where you could use it, similar, and a lot of these biologics, you can kind of use them interchangeably for the most part, as long as they have the same mechanism. So if someone doesn't respond super well to Enbrel, they can try Infliximab. Efficacy-wise, it should be roughly the same, because again, they're doing kind of the same thing between the two there. Now, in some cases, it was interesting is you can actually give this drug with methotrexate and actually can prevent immune reaction. Because one of the concerns you worry about, especially with giving these proteins over the long term, is you can have sensitization that can occur there. So the best case scenario, you may have inactivation of the drug to where it would basically your body is reacting to it and inactivating it, or you could worry about actually having an anaphylactic sort of reaction developing there. And so what's interesting is that when you give it methotrexate, you can actually have to prevent that from occurring there. And that kind of makes sense why that would work. What is methotrexate doing to your immune system? It's suppressing it, right? So if you can suppress the immune system with methotrexate, then you can't really generate a lot of antibodies against the infliximab potentially. So that is kind of one kind of interesting way to circumvent that issue there. It helps to, for the patient, again, infusion reactions are very common when they have those antibodies developed against the drug, and you certainly can see some decreased efficacy there. So by giving methotrexate, you can help to retain efficacy for a longer period of time, theoretically. Which can be beneficial for your patients. Again, I'm not going to quiz you on the dosing, but just to kind of give you an idea, this one's probably a little bit nicer from the dosing standpoint, because again, you give it, say, at week 0, and you give it at 6 weeks after the first dose, and then every 8 weeks thereafter. So they can get this one every 2 months. So it's kind of nice because it'll stick around for a long period of time. They don't have to come in frequently to have this infused. And so again, from a patient quality of life standpoint, that can be an important consideration, is how often you have to give the drug. Now this one has to be infused, and actually if you were to look at, I didn't even think about it, I should probably capture a screen grab of an order for Remicade that we're giving for some of our patients, because you'll see they have a big titration that's built into it. So basically we'll give Remicade say a big 250 ml bag of saline, for instance, and it'll say, okay, start off at say 0.5 mLs per kilo per hour. You start at a very low rate, and then gradually, as the patient's tolerating it, then you can gradually titrate up on the rate that you're infusing the drug to where you can get it basically in over 2 hours. And the point of doing that is what, do you think? Yeah, you can look for reactions basically, because again, you don't want to start giving them, blasting them full bore, infuse it super fast, because if they have a reaction, it's going to be pretty severe. So if I can slow that down and see how they tolerate it, I can gently titrate up. And if they have a reaction, slow it back down, kind of deal with that reaction, and then I can try to titrate back up again. Now, if they do have an injection reaction, it's happening there, how would I treat that, do you think? Same as any other anaphylactic reaction, how would I? So epi could be one option to give. What would I give before that, potentially? Benadryl is a big one, good, so an antihistamine. Steroids, yeah, so something like hydrocortisone or methylprednisolone. So a lot of times you're going to find, especially if patients having a history of having a reaction to these drugs, they'll actually get pre-medicated. So they'll give them a dose of Benadryl and a dose of methylprednisolone. They won't give them epi. Epi is only really if they have a true blue kind of anaphylactic reaction, they get hypotensive, throat swelling, all that good stuff. But they'll get pre-treated because they know they're going to have a reaction, and then you can give the drug. And then if they have another reaction while they're actually getting the drug, then you can give them again Benadryl, steroids, and then possibly epi if they get really severe in those cases. That kind of makes sense. So again, give it less frequently, but it's one of the things that it's kind of set aside 2 hours to go into the infusion center, get it administered. It's not as convenient as getting something like a little pen you can just inject yourself with, like we'll see with something like Humira in just a little bit. So obviously increased risk for infections, similar to all the other antibodies we're talking about here. All right. So adalimumab or Humira, this is again another monoclonal antibody specific for TNF alpha. It's all human-based, so again, there's less risk for anaphylaxis, which is beneficial, and you can tell that based on the U that's in the name there. So all human, less allergy risk. This one is a lot easier for patients to kind of take at home. As I mentioned, it kind of comes in a pen, but you do have to dose it more frequently, so they have to kind of give it to themselves every other week. And consider, like, what is their actual function, or how good is the function of their hands? Like, can they actually manipulate the pen, or do they have a caregiver they can perhaps give that to them? Because it can be very difficult to try to coordinate all of that if your joints are truly well and deformed and inflamed and all of that. And again, very similar reactions to what we saw before. Injection site reaction is a big one. Immunosuppression, nothing really new there. So those are the three kind of big TNF alpha inhibitors that we're going to I'll focus on, for like testing purposes and things like that. Just know there's a lot more that are out there, like golimumab and all those other ones. But for our testing purposes, if I focus on it here, then it's a game for the test. So just be aware of that, right? So this is a different mechanism here with the batacept. This is more for moderates to not to sever. You don't want to sever your patients typically, I guess, unless they're getting surgery, but moderate to severe disease who've kind of failed other therapies. Typically like your TNF alphas are going to be kind of your first line biologics you're going to go with. This one's another option here, and this actually binds to 2 different CD receptors and helps to prevent the activation of those immune cells there. Less T cell activation means less inflammation overall. Let's see, and again, patients, again, this is another one you can potentially give by itself or in combination, especially with another, say, like traditional DMARD like methotrexate or hydroxychloroquine. And this is better for patients who kind of fail the TNF blocker. So if they fail something like Infliximab, they fail Humira, you can switch them over to this to see if they have any kind of increased efficacy. Not everyone responds, but maybe half the patients will do well on this one. And again, not a whole lot is from the nothing unique, I should say, from the adverse effect standpoint compared to the other antibodies we're looking at today. Next we have rituximab. We talked about this previously in the cancer section. You guys remember this one? Yeah, so this one's binding to CD20 specifically on the B lymphocytes. This is another one you do want to watch out for allergic reactions, because again, it's going to be chimeric, so I have some mixture of human and mouse protein. And you'll see it's used for other autoimmune conditions as well. I see this a lot for like lupus nephritis and things like that to try to deal with that inflammation. However, again, decreasing activation of these B cells and T cells by binding that CD20. You will find that you will have a pretty big depletion of your B cells that are present, and actually it takes a while for them to recover, so several months. So you may even find if you discontinue therapy with rituximab that they may have a kind of sustained immunosuppression for several months. So you do want to be careful with that. Just know that they've received it. Kind of note when they last received it to kind of get a feel for if they're developing infections months down the road is probably related back to that. And again, if they are failing, a traditional DMARD, or they failed something like TNF alpha blocker, this is a good second line to try from that standpoint. So you can try moving from a TNF alpha blocker over to something like rituximab. Again, this one is really bad for causing a lot of allergic reaction and injection site reactions, so you need to pre-treat that one first. So similar to what we saw with Infliximab a few minutes ago, steroids, antihistamine are going to be required beforehand. Sometimes we'll give some Tylenol too, because again, you can see some fever, it kind of develops from some of that. But we'll give them Tylenol as well in some cases, and then have the epi ready at the bedside to go in case they do have a true blue reaction there. And then, yeah, again, all these biologic DMARDs can be given in combination with the traditional. So things like methotrexate is a common combination one. So they may give methotrexate daily, and they'll come in every couple of weeks or so for their rituximab. So then another mechanism here, we have tocilizumab, Actemra. I'm starting to see a lot of this being used. A lot of kids are being switched over. And again, I'm only speaking from my pediatric standpoint, and we deal a lot with the infusion center every day at the hospital with these kids coming in. So I see a lot of patients being switched over to tocilizumab. And this one's working by blocking the activity of IL-6 or interleukin-6. It'll bind to that, inactivate it, and again, interrupt that inflammatory cascade. Typically, a lot of patients will switch over to this after they fail a TNF alpha blocker. So again, these are all kind of good second or third line agents to try if something like an infliximab or adalimumab is not working for them. Again, infusion reactions are pretty common. This one is a unique one. You can see GI perforation. I don't know how common that is. Probably, I imagine, pretty rare, but that is one kind of unique sort of side effect you may want to watch out for, especially if you have any kind of nuanced that GI complaints or anything. Would be something to look into. And uniquely, this one actually will induce CYP3A4, so you got to be careful with drugs like warfarin. Could be potentially affecting that. Birth control, statins. So again, just keep that in mind. Run your interaction checker before prescribing these drugs, because again, their effects will stick around for some period of time after the last injection due to the fact they're proteins and they hang around for a while. Okay, so those are the main biologics we'll kind of focus on from this standpoint. Again, there's a lot more that are out there, but these are the ones I see commonly, and I would recommend you at least be somewhat familiar with. Were there any other big ones that Dr. Vai covered? Seems the list seemed pretty consistent for the most part. Yeah, that's good. Okay, well, if there's anything that you remember, shout it out and I'll try to talk about it. But anywho, so there's probably about a 30% failure rate for some of these patients. You may find some patients will have a primary lack of efficacy where they receive the drug for 3 to 6 months and really don't see any benefit from it. But you could have a secondary lack of efficacy, and that could be related back to an immune reaction that your body is generating against the drug itself. Anytime you inject a foreign protein, you have that risk of sensitization, so it could be what's going on here. So if it's working at first for a while, and then all of a sudden you start to see this losing the efficacy, this is where something like adding on methotrexate can be useful here, or switching over to one with a different mechanism might be a good option, or a different, so even going from Enbrel to Infliximab might be okay, because again, the proteins are different enough where your body won't be able to cross-react between those two. So, and again, we will oftentimes see combination drugs for these patients, but do not mix two biologics together at the same time. The immunosuppression is really just too much for most patients to handle, and risk for infection really goes up big time. So do not mix these two together, or two biologics together, but a traditional biologic, totally fine. Two traditionals, also totally fine to do that.
You have to wait a while to switch?
Between something like two biologics?
Yeah.
I would say I would wait whatever the typical like dosing time frame. So for instance, if I was giving Infliximab every 8 weeks, I would probably wait 8 weeks after the last dose to switch over. Again, if Dr. Vai may have a different perspective on that, but that would make sense to me to at least give it time to where the drug shouldn't really be, most of it should be gone for the most part, and then you can kind of move over to something different, I would think. But again, talk to someone who does rheumatology all the time and I have a different answer. Okay. Now, as far from, again, we'll use corticosteroids. This is really good for kind of acute inflammation, acute exacerbations of this. We know this really potent anti-inflammatory immunosuppressive drugs. They'll interfere, at the nuclear level to inhibit transcription of a lot of those inflammatory proteins. So, less T cell activation, less prostaglandins, leukotrienes being formed. So they're really working from, again, top of the pyramid down to inhibit that inflammation. It's very good, but lots of side effects associated with them, as we know. So you may find that for RA patients specifically, they'll be on corticosteroids, low-dose corticosteroids every day. Again, we don't like to use corticosteroids long-term if we can avoid it, but a lot of patients will end up having to utilize this. And again, relatively low dose, compared to something like an acute exacerbation would be. So we'll talk about bridge. Anyone know what bridge therapy is? What does that mean? Yeah, so if I was trying to transition, so say they come in for like an acute exacerbation, I can bridge them over, kind of deal with that inflammation immediately, and then give them something that is going to take a while to kick in, like a traditional DMARD or something like a biologic, give some time to kick in, and then I can pull them off of that. I can titrate them back down off of that. And how long does someone have to be on a corticosteroid where I have to worry about titrating off due to adrenal suppression? Like longer than a week, right? So longer than 5 to 7 days. If it's longer than that, they need to titrate off of there because, again, they're going to have adrenal suppression. Okay, you can be careful with that. Typically, you're going to find that we'll use parenteral administration, like intramuscular or IV administration, for those kind of short-acting kind of burst therapies. But you could also have some longer-acting depot forms. It's nice because it has a natural taper kind of built into it, because again, you inject like a big depot dose into the muscle, it will give it a nice long taper effect where you don't have to worry about building in a taper because it kind of does it itself, and there's less withdrawal from that standpoint. However, you want to make sure a patient is going to respond well to that drug before giving it. So again, anytime you do an injectable depot drug like that, once it's there, you kind of can't get rid of it. And so you want to make sure the patient has experienced it before to know if there's any like intolerable side effects, if it's even going to work for them. I have one really interesting case. So you guys, we talked about opioids being a problem. They actually have a long-acting antagonist you can actually use as a depot form. They inject into the muscle that will prevent, if someone does uses an opioid, it would block its effects essentially. So we'll talk about, anyone know what we use to reverse opioids right now? Yeah, we use Narcan, like naloxone. This is basically like a longer-acting form of a very similar drug that we inject in the muscle. But one of the things they recommend is that the patient needs to have not taken any opioids for a while, because once you inject that drug, it'll actually kick the drug off the opioids off the receptor, and then it puts them into what? Into withdrawal, right? So again, this is not very comfortable for a patient to undergo opioid withdrawal. And so I remember there was one case that we got called into a poison center where patient said, oh yeah, I definitely have not taken any opioids. I swear I haven't taken anything. And said, okay, well, we're going to inject this into you. And if you have taken any opioids, you're not going to be feeling too good. He's like, no, I haven't done any. Sure enough, he'd been doing something like the night before, injected it into him, and then immediately was going into full-on withdrawals and just having massive diarrhea and was sweating and just super cranky, and basically going cold turkey all of a sudden, right? And so the problem is, once you give that drug, can you get it out? Nope. Well, unless he chops his arm off or something. So you be careful with these long-acting depot forms. Like once it's there, it's not coming back out, right? Okay, and I mentioned another way we can administer these corticosteroids would be with intra-articular steroids. This is nice because it allows for localized effect, kind of limit the systemic effects. You don't see a ton of leakage out from the joint. However, not going to be preferred if the patient has a lot of joints that are being affected here. If it's only like 2 or 3, it's going to be better for them because again, no one likes to get a ton of shots if they don't have to. Now, one thing we do want to be careful of is you don't want to give intra-articular corticosteroids too frequently. So recommend no more than 2 or 3 administrations in a year. So really only if you're having kind of like an acute sort of inflammation, if it's something where, this can't be an all the time kind of thing because you can actually see increased joint destruction and tendon atrophy that can occur long term. So again, one thing it's very effective and it's very good for decreasing the inflammation, but don't want to give it too frequently because you can have kind of long term issues along with that. Okay. Now again, lowest dose possible should be utilized. So again, start low dose, titrate to kind of effect, and if you can, try to titrate back down if the patient can tolerate it. You may see some, decreased progression disease in the first few years. However, we worry about kind of long-term effects, and we worry about a lot of the side effects that are associated with it. So it's very much a double-edged sword when dealing with corticosteroids. And so again, adverse effects, obviously it's affecting that HPA axis, suppressing that. We worry about osteoporosis, so it's really important to make sure we're supplementing with calcium and vitamin D to try to help stave that off as best we can. Cataracts, hirsutism, hyperlipidemia, hyperglycemia, all these things are going to be along with that. So we know that based on, we've talked about corticosteroids, several times before. And it's also going to be immunosuppressive, so infection risk is going to go up. If I'm mixing corticosteroids on top of methotrexate on top of Infliximab, guess what? Infections are a very real possibility there. Okay. Anyone know any good examples of oral corticosteroids we could utilize? Okay, Medrol, you know what, the generic? Methylprednisolone, that's a good one. What else? Dexamethasone, prednisone, and then the liquid form is called prednisolone. Those are the most common ones you're going to run into. Sometimes you may see hydrocortisone being utilized. The brand name for that is Solu-Cortef. That is what that is. Those are the most common ones you're going to run into. So just kind of keep that in the back of your mind. If it comes up on a test, be familiar with those kind of common names. Okay. Anywho, then moving on to NSAIDs, you're going to use these pretty frequently. Now, do you think these do anything to disease progression? Not really, right? They only really treat the symptomatic effects here. They only decrease that inflammation, and again, only when the drug's around, essentially. So it's not going to be good for the long term, but it's good for symptomatic management. Again, they have good analgesic properties, good antipyretic properties, and a lot of them are available over the counter. You'll see we still have quite a few that are available as a prescription only. What are some good over-the-counter NSAIDs? Ibuprofen, naproxen, anything else? That is not over the counter, at least as far as I know. The other big one I will classify with this is going to be aspirin. So aspirin is, again, still working sort of as an NSAID. We know there's a little bit of difference there, as we'll talk about again, refresh you. But aspirin would probably be considered in this category of NSAIDs, because their mechanisms are inhibiting cyclooxygenase. So it's going to help to prevent that production of prostaglandins, which are going to be very much on the inflammatory side of things. So decrease that. Is going to be good for inflammation. What other problems can I run into from decreasing prostaglandins, though? Yeah, so you worry about some bleeding risk. Is the other big thing? Yeah, so why do we get ulcers? Yep, good. So we need that protective barrier, and prostaglandins are a very important part of that. If we don't have that, then we can have that stomach acid kind of eating through the lining, and then boom, you have an ulcer. We'll talk more about stomach ulcers and related to NSAIDs and whatnot in the GI section a little bit later on, but just know this is going to be an issue, and this is when we talk about COX selectivity that we will be referencing that particular side effect there. Anywho, So typically, NSAIDs are going to be an adjunctive treatment to analgesics in osteoarthritis. So again, going back to OA, typically you're going to find that NSAIDs are good, kind of occasionally being used for osteoarthritis. Sometimes they'll be used alone, but oftentimes you'll see them used in combination with acetaminophen for a lot of OA patients. However, for chronic treatment, RA is going to be one of the mainstays of therapy. You'll find them being on a lot of these NSAIDs, usually on the chronic standpoint. And then if you had to think about, like, how often do you give something like ibuprofen? When you take it, like every 6 to 8 hours or so. So from a patient standpoint, if I have RA, I'm taking this chronically, do I want to take a drug every 3 to 4 times a day? Not typically, right? So you're going to find that for like chronic treatment of RA, we're going to find there's a few of those NSAIDs that actually have long durations of action. So you only take it like 1 time a day. So again, think about how often these patients are having to take their medications. If you can limit that and try to minimize the dosing frequency, that's going to be beneficial for them, because again, you worry about compliance being an issue with these patients already. Another thing you think about, how do what's on a lot of the pill bottles that you get from either the pharmacy or from over the counter? Child protection. Does it only protect children from entering the bottles? No, it can protect older patients too. And what's interesting is the way they designed those, they had to make sure that enough children could not open them in a certain time frame. So there's actually, I saw some videos where they actually show like kids they just videotape kids just trying to open these bottles of pills to see how quickly they can get into them, usually like toddlers. And they have to make sure that enough older patients can still get into them, because again, you want to keep out the patients that actually need to open the bottles. And so, are they perfect? No, they're actually not that great, because again, kids can very easily get into them, and older patients can have a very difficult time opening them up, especially if they have RA, if they have osteoarthritis. They can have a big issue getting into them. So it's important to consider, make sure that they educate them to request things like easy open bottles from the pharmacy, so that way they can not have to worry about the childproofing issue, and then also make sure they are keeping those pills in a place that children cannot get to them, because they'll be that much easier to get into.
Mm-hmm. So it has like the easy open. I didn't realize what I did a few weekends ago, but I was like, man, this is just
this is weird.
Easy. And then I
yeah.
Listened, yeah, you can just like flip the cap.
Yep, yeah, we've had that a while, like at places like CVS and stuff, and yeah, it's beneficial, because again, we don't have to carry one type of cap, and then you have to like carry 2 separate ones or something. But a lot of the over-the-counter stuff you get doesn't have that option. So again, a lot of it is child protected, and yeah, it's really not that child protective. Nothing is child proof, we should say, right? If you're child resistant, nothing is child proof. They are very wily, and they have more time than most adults do to put their heads against a problem, and then they will overcome most anything. As I'm finding out daily. I was like, how in the heck did you even get into this room? The door is locked. She's like, Okay, well, let's go watch Minions again. Anyway, so again, you're going to find that the NSAIDs do not modify disease progression. They do not slow anything down. They're really only treating the symptoms here. Again, do they treat the disease progression in OA? No, they're only going to deal with the symptoms, right? So again, NSAIDs are not good for that. We'll find pretty variable patient responses. Everyone might have a few little differences in their COX enzymes. So they may not respond well to one variety of NSAID. Doesn't mean they don't respond to any NSAID. It means you can just vary it up a little bit, try different options to see what they respond to well. And again, there's nothing to say that we should utilize combination NSAIDs. You really shouldn't combine more than one at a time. However, it's okay if you have a patient who's on like 81 milligrams of aspirin for cardiovascular protection and an NSAID. You're not going to find too big of an increased risk for side effects, but just be aware. You look for things like bleeding, bruising, etc. But generally, it's pretty safe to have both these patients on these. Now, we'll talk about COX-2 inhibitors, because we said most NSAIDs are going to be non-selective, but we'll look at a few COX-2 inhibitors. And again, with selectivity of enzymes, very similar to what we saw with beta blockers, nothing is 100% selective. So you're going to find it's all going to be kind of shades of gray here. We're going to find that if you used a pure COX-2 inhibitor, that actually was killing people, and we took those off the market. So most of the NSAIDs we have now that are claimed to be COX-2 selective are mostly COX-2 selective. They still will inhibit COX-1 to some degree, right? So not perfect, but we'll find that they kind of mitigate some of the GI effects we've kind of alluded to already. Okay, but generally, use the non-selective ones for most patients, and if they're kind of high risk for things like NSAID-induced ulcers and whatnot, that's where we can utilize things like a COX-2 inhibitor. Okay. So, Again, low risk for GI complications. NSAIDs are good, but they're high risk, and then COX-2 inhibitors are going to be better. However, you can use non-selective NSAIDs plus some sort of gastroprotective agent. So you could use something like, we talked about misoprostol before, or kind of mentioned that in the OB-GYN section. Again, this will be contraindicated in what type of patients? In pregnant patients, right? Because we said it's an abortifacient. You can produce an abortion. You can also use things like PPIs or proton pump inhibitors. Anyone know any examples of those? I know you've talked about them already in GI. Protonix, there's pantoprazole. This is lansoprazole, there's rabeprazole, there's omeprazole, esomeprazole, so the prazoles, I guess the naming convention kind of look forward to look at those. You can mix those with the NSAIDs, and that will give you pretty good gastric protection, because again, PPIs are doing what essentially? Shutting off the proton pump that actually is producing that stomach gas, right? So less hydrogen ions flowing into the stomach, less acids, less lowers or increases the pH of the stomach contents, and will help to prevent even if that barrier is kind of compromised, we won't have the ulcers actually forming there. But and again, the reason why we say high risk for cardiovascular disease, use NSAIDs if necessary. We'll look at that why that is. But when you found drugs that were only COX-2 selective being utilized, anyone ever heard of Vioxx before? You guys are way too young to have probably heard of it in a lot of cases, but Vioxx was one that was a pure COX-2 inhibitor, and a lot of people were using it like crazy. It was like a blockbuster drug. But when they're given to millions of patients, they found there was an increased risk for cardiovascular death. A lot of it goes back to angiogenesis and actually inhibiting it when you only inhibit COX-2. I'm not going to get super into the weeds on that, but just know that there is a theoretical risk for some of those patients. Using non-selective NSAIDs is probably going to be a little bit safer overall, but if you can avoid it, that's always going to be preferred, right? Fewer drugs are usually better. So, looking at an algorithm for rheumatoid arthritis, we'll start off with a patient who's DMARD naive, never been on one before, and say either low to high disease activity. We're going to start off typically with something like a DMARD. Methotrexate usually is going to be good for most patients, and you start. You can start with prednisone, right? So we said prednisone, what type of drug? Corticosteroid, right? And so this would be what type of therapy with this one, do you think? It's that bridge sort of therapy, right? So they're having disease, having symptoms already occurring. You can give them the prednisone to try to get them symptoms under control while the DMARD kicks in, right? So over a couple of months, and then hopefully you can titrate off the steroid, because again, you always want to try to get them off the steroid as best you can. A lot of patients you may not be able to do that, right? Okay, so then, still having moderate to high disease activity, this is where you can consider using combination DMARD or something like a TNF alpha inhibitor plus or minus methotrexate. So again, you can utilize a traditional DMARD plus a biologic. That's an okay combination. Don't use two biologics together. You can use two traditionals together. So I can use hydroxychloroquine plus methotrexate. That would be fine. But I don't want to mix like rituximab plus infliximab. That would be just way too much from an immunosuppression standpoint. We want to avoid that. And then say for instance they fail a TNF alpha inhibitor. This is where you can utilize the combination therapy. Is going to be more kind of recommended in that case. You can utilize a different TNF alpha inhibitors. So if like Enbrel didn't work for them, maybe try Humira, see if that works. Otherwise, you consider using like a non-TNF biologic. So you utilize something like a rituximab, or using something like a Orencia or something like that. And then you also consider that tofacitinib. Again, that's the newest drug in the bunch. So again, we don't have as much evidence or much experience with this use. So they're kind of limiting it to when you use it kind of later in the progress. Because again, there could be things we just don't know about the drug until we kind of use it in a lot of patients. That kind of makes sense. Anyway, so again, a good stepwise approach. You usually start with methotrexate, use steroids only as needed, and then look at adding on like a biologic if needed. Some patients may start off on a biologic, but I don't see that quite as often. But usually methotrexate's a kind of good one to start with, because again, it's an old drug. We know a lot about it. It's pretty cheap. However, if I said you had a patient who was just diagnosed with RA, they have existing renal and hepatic issues, that may not be a good candidate for methotrexate. It may give you an option to switch to use something like hydroxychloroquine or something like Infliximab, something like that. So those are kind of questions to think about in regards to drug selection for these patients, right? Okay, like I said, I mentioned with traditionals, you can utilize two traditional agents together. So MTX plus hydroxychloroquine, sulfasalazine, any of those combinations are totally fine. In some cases, you may even see three traditionals being used together. This is done more commonly before the biologics were available. But however, you probably want to avoid methotrexate plus leflunomide due to a risk of hepatotoxicity. It can be kind of synergistic from that standpoint. So you do want to be careful with that combination. Using traditional plus a biologic is totally fine as well. So MTX plus Infliximab, totally fine. Humira plus, another, say like hydroxychloroquine or something like that would be totally fine as well. Any of those are good. Again, no mixing of two biologics though. Okay. How much time? I have a few minutes left. Let me see where I'm at. 60 out of 102. You guys want to call it there? Give you a few extra minutes. Okay. So we're going to stop it there. Any questions you guys have? I want to burn all my slides for next time. But anyway. Okay. So no question. I guess I'll see you guys next time. Thank you.